I have limited time, so I'm going to stick to 3 scenarios. And the first one is this 4-year-old comes in referred for strabismus and low vision referral, has a large angle esotropia, has high myopia, has a myopic fundus. This patient has an undiagnosed syndrome. How can we know? Well, we have a secret weapon as ophthalmologists no other medical specialist has. We can look at the vitreous. And you look at the vitreous in this child, and it's beaded. This is a normal vitreous, just to remind you. This is a beaded vitreous. This is pathognomonic for collagenopathy. And sure enough, you take a look back, the child has a flat face. We ask some pointed questions. She's hard of hearing. The parents didn't even realize it. They were surprised when the child said, yes, I'm hard of hearing. This patient has undiagnosed Stickler syndrome. Now, Stickler syndrome is a collagenopathy, one of several different collagenopathies. We know about Stickler syndrome from the risk for retinal detachment, from the very high myopia, hearing loss, flat face. But some of these patients present with ocular-only findings. And only the ophthalmologist can diagnose or raise suspicion for the diagnosis. And looking at the vitreous is very, very powerful in these cases. Again, this is a normal vitreous. This is the membranous vitreous that's classic for collagen 2A1 mutation. It's virtually pathognomonic. And then the beaded one, typically collagen 11A1 mutation. Again, someone comes in with flat face, hearing loss, high myopia. It's not hard to suspect Stickler syndrome, but they don't always come in like this. Sometimes they just come in with the myopia. And again, looking at the vitreous, this is the beaded vitreous phenotype. And you see in the diagram and you see in the picture, look at this, remember it, get used to looking at normal patients so you have a sense of what the normal vitreous is so we can pick these patients up. This is not normal myopia. This is the collagen 2A1 phenotype, the membranous vitreous. Again, you can see in the picture corresponding to the diagram. That's pathognomonic for collagen 2A1. These patients also can get lens opacity. Here's another 4-year-old. Again, the same story, referred with high myopia, hard of hearing. We see the vitreous. We suspect it's Stickler syndrome. But why am I showing you this? There's another clue in this patient. Look at the choroid in this patient. Normally, if you have a -16 patient, the choroid should be thin. But in Stickler syndrome and these collagenopathies, it's not always thin. And this is a clue that you're not dealing with the normal myopia when you see a normal-sized choroid in such a high myopic patient. Another collagenopathy that we encounter in the region is Knobloch syndrome. Knobloch syndrome is typically a triad of occipital encephalocele, retinal detachment, high myopia. But many of these patients come in with ocular findings only, and we can diagnose them just from the ocular findings. They don't have to have the encephalocele. The ocular phenotype is specific, and you can actually start with the front of the eye. The iris is cryptless, the iris is flat. There's often a little bit of ectopia lentis. There doesn't have to be, but it's the retina that's pathognomonic. They have this chorioretinal atrophy much more than you would expect for the degree of myopia because it's a primary retinopathy. It's not a stretched eye from high myopia. They have a macular defect. They have the choroidal vessels radiating from the center, and they have a fibrillar vitreous. This is pathognomonic. Nothing else can cause this. This is collagen 18A1 mutation. This is a series of Knobloch syndrome patients. Look at the refractive error they come in. They come in as high myopia, and I've seen many of them just diagnosed as high myopia and amblyopia. But no, they're not Knobloch syndrome. They have a retinopathy. This is a genetic disease. They have a very strong predisposition for retinal detachment as well. These are 3 different patients with Knobloch syndrome. They all look like they're the same patient because it's a pathognomonic phenotype. Again, that macular atrophy, the choroidal show, the choroidal vessels radiating from the fovea, the amount of choroidal show out of proportion to the amount of myopia. And again, if you focus the camera anteriorly, you see the fibrillar vitreous. Let's move on to the next undiagnosed syndrome. It's represented by this 4-year-old referred with reduced vision. She has myopia. She also has a little bit of microcephaly. She was just diagnosed as myopia. But when you look at this patient in the peripheral retina, there are these punched out lesions and it's not completely vascularized. We must look in the periphery of these patients who come in with high myopia because sometimes it's a sign of abnormal angiogenesis. Angiogenesis is new blood vessels from existing ones. It's VEGF dependent. It's what's dysregulated in ROP and also in fever. And when these patients are severely affected, they come in with tractional retinal detachments, retinal folds. But when they're mildly affected, they come in with myopia and minimal peripheral changes, which may not be diagnosed unless you look for them. I'm not going to go into the genetic mutations. Just understand that a patient comes in with myopic, we have to consider that it could be an undiagnosed fever or ROP and look in the periphery. This is an obvious patient with fever, okay? But this is the father who has the same mutation and he's myopic and you look at his posterior pole, it looks fine. But you look in the periphery, it's not completely vascularized. Milder causes of fever sometimes are just diagnosed as myopia when it's actually part of a retinal angiogenesis problem. This is a series of fever patients, 80% of them myopia, 50% of them high myopia. Suspect fever in these patients. Look at the periphery when you have myopic patients. The final scenario I'll share with you is a very common one, 6-year-old, strabismus referral, high myopia, has poor night vision, seen by a retina specialist, told the retina is normal. But when we ask the mother, the patient has poor night vision, the multimodal imaging is all normal. When you have normal multimodal imaging, high myopia, and vision that doesn't correct to 20/20, or a complaint of poor night vision, you have to do electroretinography. Because while many retinal disorders, inherited retinal disorders, have abnormalities on multimodal imaging, some of them don't. And just because you have normal multimodal imaging, it doesn't rule out an inherited retinal disorder. The only way to know is to test the retinal function, that's ERG. And sure enough, this patient has undiagnosed congenital stationary night blindness. I can't tell you how many patients I've seen who have high myopia and undiagnosed congenital stationary night blindness because the only way you can diagnose it is with an ERG. Multimodal imaging can be normal. So consider this. Any patient, high myopia, doesn't correct to 20/20 or is complaining of poor night vision, needs to be evaluated for possible inherited retinal disorder. So my time is limited, so I think with that I will end. And thank you very much for this opportunity to speak.